So thank you to the organisers for the opportunity to speak to you today. I'll be talking about antiretroviral-based PrEP, a bit of an update on the science, and also Scaleup. Here are my disclosures. I'll start with the scientific update. So as we all know, it's been a decade since the first evidence on PrEP was released in the IPREC study in 2010, and the effectiveness of daily oral PrEP has been proven now in randomised trials, demonstration projects, large-scale implementation trials, and in real-world implementation. And we now know that daily oral PrEP is close to 100% effective in adherent individuals, and there is a well-established relationship between adherence and effectiveness. We've also seen that the population-level impact of PrEP has been proven, even as condomless sex has increased in some settings. So we can see here's a slide from Linda Gale Becker from earlier this year from a conference showing 4 cities around the world with predominantly MSM epidemics and showing the substantial decrease in HIV diagnoses that have occurred since PrEP scale-up, of course, in combination with testing and treatment as well. We know that TDF-FTC is forgiving in cisgender men who have sex with men who only need 4 or more pills per week to be effective, but it is less forgiving in women who need 6 or more pills. And that raises questions about the feasibility of oral PrEP for women. There have been a small number of breakthrough infections around the world, sort of about 3 or 4 at this point that have been really proven. And persistence on daily PrEP in individuals at ongoing risk of HIV has been a challenge in many settings. Here's just a little image from a couple of years ago in Thailand showing the relatively small proportion that were retained on PrEP at 12 months, although I do hear that this has improved markedly in the last couple of years. We also have a second drug that can be used for daily oral PrEP in men who have sex with men and transgender women, which is the new version of TDF, TAF, along with FTC, and this is known as FTAF. The next thing that came along was obviously on-demand oral PrEP, or event-driven PrEP, or 211 PrEP. And this is where people take 2 pills 2 to 24 hours before sex, and then 1 pill per day for the 2 days after sex. This is for men who have sex with men who have sex less than twice a week and who can anticipate when they're going to have sex or at least delay sex for 2 hours, but it's not appropriate for other population groups. This is starting to be recommended in global guidelines such as the WHO guidelines, and national level guidelines are starting to include it as well. That's happening a little bit more slowly. Now here I just want to mention that oral PrEP has had other impacts as well that have been particularly reported in the qualitative literature, but also in the quantitative as well. We see PrEP users report reduced HIV anxiety, sex free from fear, sometimes for the first time in their lives, increased pleasure and intimacy, increased empowerment and control, particularly in young women in sub-Saharan Africa, and the potential for reduced stigma towards people living with HIV, obviously combined with U=U. But there are still some issues for consideration for PrEP implementation science. Adherence does continue to be a problem, and we need to have investigation into better ways to support adherence because generic TDF-FTC is still going to be the PrEP mainstay for some time, even though we do have some new products coming along. Early discontinuation continues to be a problem, but we need better acknowledgement that individuals only need to be on PrEP when they are actually at risk of HIV acquisition. And this is known as the prevention effective adherence paradigm. So we need better understanding of long-term patterns of oral PrEP use, including why people cycle on and off and how these decisions are made. And here's just a pictorial example from Sirota et al. In CID in 2020 of showing graphically the sort of complex patterns of PrEP use that can happen in a cohort of PrEP users. And it's quite hard to actually measure this kind of thing in a research study. We know that oral PrEP is highly effective and safe, so we need to understand the policy and regulatory barriers to innovative PrEP models and the demedicalisation of PrEP and find ways to address those barriers. And on-demand oral PrEP is still slow to gain traction in some settings that initially started with daily oral PrEP. It's really only gained a lot of traction in France, Belgium, and the Netherlands. This could be partly due to low awareness of it, but also there's low knowledge of the specifics of how to take it. And this is a concern given that it is less forgiving than daily PrEP. And another problem with it is that it is seen as more complicated by some potential PrEP users and by clinicians. So the next thing that came along, and we might call this PrEP 2.0, is the dapivirine fed vaginal ring. And this is a monthly ring used by cisgender women And that's been proven to reduce the risk of HIV infection by up to about 30% in the clinical trials. But as was seen with some other PrEP products, effectiveness improved in the open label extensions of these trials up to about 50% reduction. This is now being recommended for use in women, particularly in lower middle income countries. And it's currently working its way through licensing processes in several African countries. And I know UNAIDS in Bangkok is very interested to understand how this product might play a role in our region. Of course, the big recent news is what we might call PrEP 3.0. And this is the long-acting injectable class of drugs. And the first one that started this is cabotegravir, or CAB-LA. This is an 8-weekly injection that's being trialled now in 2 very large randomized controlled trials. HPTN 083 was for men who had sex with men and transgender women, and 084 was in cisgender women in sub-Saharan Africa. Both of these trials found that injectable CAB-LA and oral TDF-FTC were both highly effective. And so even oral TDF-FTC was very effective as compared to what the incidence would have been in the absence of any product. So in 083, in men who had sex with men and transgender women, the reduction was about 66% comparing the 2 products. And in 084, it was 89%. So the authors have talked about this as cabotegravir being superior, but it needs to be remembered that these studies were done in locations where adherence to daily PrEP was a little bit lower than what has been seen in some other areas, such as in Australia, where adherence is very high. There are quite a few issues to consider for implementation and implementation science for this new product. Injection site reactions were common, but did not lead to much discontinuation. There were a handful of breakthrough infections seen in individuals who had visited and got their injections on schedule and had concentrations of cabotegravir in their plasma that should have been protective. And this is a bit of a concern, and we'll need to see how the community responds to this kind of information. They also saw delayed detection of HIV infections due to suppression of viral replication. And the authors suggest the use of more sensitive viral load testing, and this is being explored in the open label extensions of the studies. One big issue for cabotegravir is the long PK tail. So this refers to the fact that after the last injection, there can be detectable levels of the drug in the person's body for up to about a year after the last injection. But the level of drug in the body will become non-protective for HIV infection, which raises questions about what to do in that tail to protect these individuals, and also some questions about resistance. So what they found in these trials what they did in these trials, was that they gave oral PrEP for a year after the end of the trial to these individuals, after the end of the injections for these individuals. And this obviously presents a major problem or potential feasibility issue for cabotegravir rollout, because if the kind of people that you're trying to get onto this product are the very people who don't want to use a daily pill, asking them to then take a daily pill for a whole year after their last injection may not work. These trials also found some INSTI resistance, that's the class of drug that cabotegravir belongs to, in a small number of baseline and incident infections, but thankfully not in the PK tail. That was the area that people were most worried about. So we just need to watch that space a little bit more as we move into implementation. One issue for service delivery is that these injections do require more frequent visits, and this may create some capacity issues for services. And the big issue, of course, is the price is not yet known. It is likely to be unaffordable in most lower to middle income countries unless generic versions can be made available. But it's also unlikely to be subsidized in many high income countries with socialized healthcare, unless it can be proven to be cost effective to those governments. And another minor issue perhaps for Asia, but a bigger issue in some places that have well-established STI screening programs, is that the STI screening schedule recommended, which is usually every 3 months for high-risk people, doesn't match the injection schedule, which is every 8 weeks. Now, the next class of products we might call PrEP 4.0, and there's two products in this group that are both now in efficacy trials. So the first one is the long-acting monthly oral pill of a highly potent drug called islatravir that has excellent safety and pharmacokinetic properties. This is now being tested in 2 phase 3 randomized controlled trials currently underway, the EMPOWER trials. And similar to the cabotegravir trials, there's one trial in cisgender women and one in men who have sex with men and transgender women. These, like the carbotegravir trials, will be double-blind, double-dummy, active controlled trial designs. So everybody in the trial will be taking a monthly pill plus being asked to take a daily pill, but one of those two will be a placebo and one will be the active drug. And the second product in this group is the longer-acting injectable, which is a twice-a-year injection of lenacapavir. This is a subcutaneous injection rather than a muscular injection. And this has been tested in 2 trials, Purpose 1 and Purpose 2, again, cisgender women and men who have sex with men and transgender women. The trials are designed fairly similarly to the one I just described and similar to the carbotegravir. Only in the women trial, they're also going to be having an arm of FTAF because FTAF has not yet been proven in cisgender women. But the most interesting thing about these 2 trials is that they will also be using a counterfactual analysis to determine efficacy. So they'll be looking at what the background incidence would be in a cohort of people who are not in the trial, but who are similar to the people in the trial, and then comparing the incidence in the trial to that background incidence. Further down the track, we're looking at longer acting implants. So several products are being investigated for use for removable or bioerodible implants. Early results on islatravir show that the implant has been well tolerated and the implant releases drug through 52 weeks. And so this means that it could be formulated into a once yearly implantable option. And people are very excited about the potential for PrEP to be then combined with contraception into the one product to make a multi-purpose technology. So for the next few minutes, I'll just talk about Scaleup and some issues around Scaleup. So in terms of global progress, the global goal was to get 3 million people onto PrEP by 2020. But this target was unfortunately missed by a large margin. And there were probably several factors involved in this: cost, acceptability, effective use, availability, and potentially implementation issues. There are now new global targets, which include getting 4 million people onto PrEP in the Asia Pacific region by 2025, but we're not tracking so well so far. The Asia Pacific is only at about 1 to 2% of this 2025 target and accounts for less than 10% of global PrEP users. We are seeing some promising signs in terms of PrEP guidelines. So in 2018, just over 30% of countries in Asia had any form of guidelines that were recommended by their government. And in 2021, this has grown to over 60%, with some more countries having draft guidelines too. So this is great news, but there still are some countries that don't have any guidelines and have none in development. In terms of PrEP status around the region, there's 6 countries that we could say there is a PrEP national program in place, or that national scale-up is in progress in a real way. And those countries are New Zealand, Australia, Thailand, Vietnam, Cambodia, and Taiwan. There is post-trial access and PrEP rollout and limited availability in a few more countries, including the Philippines, Malaysia, and China. And several countries are still at the stage of doing relatively small stage demonstration trials. And this is problematic because we really are at the point where we are way beyond the need for demonstration trials. We now need large scale implementation rather than small trials with a couple of hundred or even a couple of thousand participants. Some countries are still at the stage of planning for PrEP, and some countries have no PrEP or no plans at all. In terms of PrEP use, Australia is the only country in our region that has more than 30,000 users on PrEP, and then followed by Thailand and Vietnam with more than 20,000. But when we're looking at this figure, it's important to keep in mind the relative sizes of these different countries' populations and also their key populations. So in Australia, we have a relatively small population of only 25 million. So the fact that we have about 45,000 PrEP users means that we have very high penetration of PrEP use amongst our high-risk gay and bisexual men. It's actually up to sort of around 65% at this point. Whereas even if you have a few thousand users or even tens of thousands of users in a country like India or China, which have over 1 billion people, then you can see that PrEP is not going to make much of an impact in that context. This is an example from Thailand, where they estimate that only 18% of the people who they believe that they estimate should be on PrEP are actually taking PrEP. But one good news story about Thailand is that 20% of PrEP is being provided by the key population-led organisations. And I think this is a model that really needs to be explored around the region. I was involved in the last couple of years in a study in 5 Asian countries surveying men who have sex with men. And we looked at awareness, willingness, and use of oral PrEP. You can see here that in these countries, awareness was actually fairly high, which is pretty good, except in Indonesia, where it was only 25%. And the willingness to use PrEP amongst non-users was also pretty high, even in Indonesia, where people hadn't previously heard of PrEP. But use was typically fairly low, with, unsurprisingly, the highest levels of use being in Vietnam and Thailand. So there still are several issues for PrEP scale-up globally and in our region. There are major inequalities in access to PrEP between countries, as I've just shown. And there's also evidence that inequalities emerge even in countries that have broad access to PrEP, such as Australia and Thailand. So in Australia, for example, we see that migrants, younger men who live outside of the capital cities, they are accessing PrEP at a lower rate than other men. And this is creating divergences in the epidemic, where we are seeing increasing rates, for example, amongst migrant men who have sex with men, but we're seeing decreases in diagnoses among Australian-born men who have sex with men. There's also a tension between wanting to target PrEP to the most high-risk individuals for PrEP and wanting to make PrEP as widely accessible and non-stigmatized as possible. So you're obviously going to get the best epidemiological bang for your buck by targeting PrEP use to high-risk individuals, but that can have the perverse outcome of making PrEP stigmatized within particular communities. And so this is a really difficult conundrum that we face in the PrEP rollout. Health systems need to be made PrEP friendly. And what this means is non-stigmatizing towards PrEP and also to key populations. There needs to be a really diverse array of locations of PrEP access. So for example, some countries have talked about only doing PrEP in, say, HIV clinics within tertiary hospitals. And that's a really bad way to do PrEP because we really need HIV negative individuals to be able to access PrEP at multiple different kinds of locations. And we also need further demedicalization of PrEP, such as in pharmacies, peer-led services, and various other models. There are still many individual level barriers, even in places with broad access to oral PrEP. These include things like low awareness of PrEP, low demand. That means we need to do a bit more demand mobilization. There can be inaccurate risk perception where people believe they are low risk for HIV, where their behavior actually suggests they would be high risk. There's always this issue of cost and also the problem of persistence when at high risk. And we need even more work to be done to understand what PrEP users and potential users want from PrEP products and services. And we will soon be launching a large survey across Asia in men who have sex with men and transgender women, looking at preferences, values, and what people want out of PrEP. Many structural issues still remain with regard to PrEP. So funding is a big one. PrEP is still donor-driven in many Asian countries with little domestic funding. There's still stigma and discrimination that gets in the way. And there are siloed approaches to HIV, whereby, for example, the HIV response has typically been done from a sort of HIV treatment point of view. And that's a very different prospect to then dealing with HIV prevention and HIV negative individuals. So just to conclude, I think we would all agree that PrEP scale up in Asia and the Pacific is an urgent priority. Most people in high-risk groups in Asia do not have access to PrEP, and this is a problem. HIV stigma, homophobia, transphobia, sex work discrimination, and drug-related stigma are high, and in some Asian countries, they're actually increasing. And we need a well-funded, community-centered, public health-based approach urgently. These new long-acting products that I've described today will start to become available in the near future, but this is not going to translate to access to people at high risk unless they are affordable and equitably distributed. And as we've seen from the recent COVID-19 vaccine situation globally, we cannot assume that just because a technology becomes available that it will be equitably distributed. We need simplification, demedicalization, and differentiation of services. These are going to be critical to ongoing PrEP scale-up. And as I've discussed throughout this presentation, there are still many implementation science questions that need answering. So I'll stop there. Thank you for your attention. I look forward to the panel discussion. And I'd just like to acknowledge a few individuals there at the bottom of the slide who've helped with this presentation. Thank you very much.